Good afternoon, everybody, and a really warm welcome. I'll just take a moment and let people come into the room and settle in as we are about to begin our second webinar in the IMPHS webinar series. It's really lovely to see some familiar faces coming into the room and some new friends as well, those that may be aware of the work that we've been delivering in the Health Champions project and obviously keen here this afternoon to hear a bit more about it. What I would like to do, because we have quite a lot we're hoping to get through over the next hour, is make a start. And what I'd like to do as kind of part of my introduction is just set out a little bit about what we're hoping to do in this webinar this afternoon. So first of all, I should say, my name is Gracie Tredgett, and I'm the project manager for the IMPHS project. If anybody isn't really familiar with the work that we do within IMPHS, IMPHS stands for the Integrating Our Mental and Physical Healthcare Systems project, which is a project that sits within the Mind and Body programme at King's Health Partners. And our interest as a team is to think about physical health interventions that can support adults living with severe mental illness. And over the course of the last few years, as a team, we've been looking at a variety of different interventions and models that we can research and test. And the Health Champions model is one that we're really pleased to be able to share with you much more about in today's webinar. So what I'd like to do is just take you through what we're going to be covering in this webinar this afternoon. Some things, I guess, to say, first of all, is that we've got a lot of detail in terms of how we've delivered this model. And what we'd like to do is hear from key people that have been involved in delivering it, not least our lead researchers, but colleagues at SLAM and also our health champions and service users that have been a part of this work. So we'll journey through a couple of key things as part of the agenda for the next while. And then at the end of this session, we have a Q&A. So what I'd like to encourage is that we invite you to share comments and reflections as we go through this webinar this afternoon. Please do pop them in the chat for us. We'd love to hear your thoughts as we go through, and we'll at the end make sure we have time to be able to discuss that with you all together. Which leads me now to say just a very huge welcome to all of you, and thank you for being a part of this webinar for us this afternoon. We're really glad to have you here, and I'm going to now hand over to Dr. Julie Williams, who's going to do our introduction on Health Champions. Julie, over to you.
Thank you very much, Gracie, and hello everybody. Nice to have you all with us. Yeah, as Gracie said, we've got a lot to cover in this hour. An hour feels like it's going to be a really long time, and then actually when you start putting it together, you realise we haven't got much time. So just to start with, kind of why Health Champions? Why did we do what we did? So we know that there's a big health inequality for people with severe mental illness. They have more physical health conditions and a higher morbidity rate. And this has been known for quite a long time, and there's a lot of research around this. And I think a lot of the questions that policymakers, researchers, clinicians, and people with that diagnosis themselves are asking, well, how can we address this? And also, I think one of the things that we were interested in is, well, how can support from volunteers help people with their physical health? When IMPHS was being developed, there were lots of people involved in starting this, and and one of the people that was involved in the original idea of Health Champions is Isabel Mdudu, who is the volunteer manager with SLAM. And she's here today. And so I thought it'd be really nice, Isabel, if you want to bring yourself on screen, that we just heard from her about kind of the original idea, where it came from and how it became part of the IMPHS project. So Isabel, welcome. Thank you very much for joining us. So I've just got a few questions for you. So first of all, can you just tell us about your role? And then also, why did you think that volunteers could help people with their physical health?
Of course, yes. So hello everyone, and thank you for inviting me to the webinar. So I'm the volunteer services manager for SLAM, and I've been here for about 12 years. I worked in SLAM before that. We have about 450 active volunteers, which we usually have every year. But with the Health Champion project, so many years ago, I'd say about 10 years ago, I was in touch with the physical health lead for SLAM, and we spoke about having Health Champion volunteers. Unfortunately, nothing happened. But I linked in with Oxley's, our neighbouring mental health trust, and they had a similar kind of service. So I thought, oh, that looks really good. But I'm really interested in physical health as well, because I trained as a dietitian many years ago. So I have that passion for health too. But so this had been happening, and we'd been thinking about it as a team. But then Kate Lillywhite approached me about 3-4 years ago, and she was looking at the funding for the IMPHS project, and she mentioned about health champions, and she said, what do you think about having volunteers involved with the health champion project? And I said, oh yes, definitely, what a brilliant idea. Volunteers provide such great skills and enthusiasm to everything that we do. They enhance services. But I said the proviso is that we need to invest. You need to have a paid member of staff who would train, coordinate, supervise, and most importantly, support those volunteers. So she said, yes, let's put it in the funding. And that's how things happened, how the whole volunteers, well, the health champion volunteers actually came about, because we initially looked at having that as a very much part of a great way forward in the health champion project.
Lovely, Isabel, and you talk always really nicely about what the benefits are for volunteers. So I think you talk about the 3 things that they can benefit from. So I wonder if you just want to sort of talk about that briefly now.
Of course, yes. So I think 3 parts to it. So what happens is we need to ensure that our volunteers are looked after, so that they have support, supervision, and also maybe a pathway for them, because a lot of volunteers are interested in getting information for themselves, but also gaining that practical experience of being able to support people with mental health issues. But this had a new angle to it. So we had a lot of interest from people who were interested in the other side of things, so the physical health side of things. But the bigger picture was having that investment in volunteers, having a paid member of staff who's going to coordinate volunteers, but as a service, making sure that the volunteers were included in teams. So it's valuing our volunteers and ensuring that they get what they need from their placement. The most important and part of it are the beneficiaries, the service users. So to find out how the service users would like to be supported by the volunteers and what the volunteers can offer, and look at that relationship and really good matching. So volunteers, service users, and the service as a whole. And that works really well, because we've had great befriending services across the trust in different forms. So we've used that, I suppose, the project plan, and used it for the health champions so that they could get an idea of what the expectations were going to be, but then also have, I know that you did this, Julie, you had focus groups to find out what would work well. And then as a service say, this is all going to happen, can you help, can you be involved, can we have good referrals, can we have appropriate referrals? And then the other thing is, what will the training, the supervision and the support for the volunteers look like, and what do the volunteers want to get out of it? So really good planning and investment is very much needed. And then for the beneficiaries, our service users say, yes, this is what I've found has helped me in my journey, whether it's recovery, whether it's their health, whether it's their goals to go on to be volunteers themselves, to be able to see that happen. And it does. You've got great feedback from people across the board.
Thank you, brilliant. Thank you so much, Isabel. I think you've given us a really good start there in kind of where this has come from. So just to say to everyone that Isabel is with us until the end, and so she'll be in our Q&A session. Please do put any questions that you've got for Isabel or for the rest of us in the chat as we go along. And when we get to the Q&A session later, hopefully we'll be able to answer as many of your questions as possible. So just to move on now. So this is our protocol paper. So we published an academic paper explaining what we were going to do. So this was a feasibility trial. So what we wanted to do was to understand, can we make this work? So can we recruit enough people? Do people like the intervention? Do they stay in the intervention? And it's called a hybrid 2 design. And this is implementation science speak. So for people that aren't, which I imagine is probably both of you, who are not familiar with that, what we mean by that is we're interested in looking at both the clinical effectiveness. So actually, how does it help people in their lives, but also the implementation effectiveness. So what are the kind of challenges? What do we need to do to be able to implement this, and what can we learn from this across the trial? And Gracie hopefully is sharing the paper in the chat with people if anyone wants to have a look at that. Okay, so if we can have the next slide, Gracie. So I'm just going to tell you a little bit about what the intervention was. So health champions are specially trained volunteers, and my colleague Ray is going to talk to you about the training in a minute. Matched with someone using community mental health services. We had an intervention that lasted 9 months with people meeting once a week. When I say meeting, what happened was we developed the project before COVID, and then we had to change everything because we were literally just about to start recruiting when COVID happened. So when people were meeting, sometimes that was face-to-face, but often that was remotely as well. And the role of the health champion was to support the person with what they wanted to achieve around their physical health. So it wasn't the health champion kind of telling them what they should be doing. It was very much understanding, you know, what people wanted and then supporting them with that. And then we evaluated, thanks Gracie, did having a health champion make a difference to someone's life? And we used outcome measures, and we also asked people about what they wanted from a health champion and whether they got it. And then also, how was it implemented and how did people experience it? So that's what we were interested in evaluating. Next slide, please, Tony. Thank you, Gracie. And now I'm going to hand over to my colleague Ray, who is going to tell you about actually what we did to support the health champions and to make this, to implement this. So over to you, Ray. Thank you.
Thanks, Julie. And guys, please excuse the background. I am actually working from my son's bedroom today, so there's a cot in the background. But anyway, I'm going to talk today about the training, the matching, and the supervision. I think we wanted to provide training before we matched health champions, and I'll talk, as I say, I'll talk about matching in a little while, but basically to provide a foundation for everybody that was signing up with us, that was volunteering, because we knew that volunteers would hail from various walks of life. Some people with lived experience of mental health, some students, some clinicians, researchers. In fact, one health champion as well, an old a tutor of mine as well, when I trained as a mental health nurse. So the training was developed by myself and by Ubong, our volunteer coordinator. And pre-COVID, it would have been 1.5 days. As Julie said, we had to change kind of delivery and how we were doing things because of COVID. So it actually got reduced to from 1.5 days down to 2.5 hours, and that was all virtual delivery. And the 2.5 hours was split into 2 sessions as well. And rather than calling them training sessions, we actually called them welcome sessions, because we wanted to kind of build the group, build the relationships from the very beginning. So welcome session 1 was 1.5 hours, and welcome session 2, which we called beginning the conversation, was just 1 hour, and that was the second part. And the rationale really for condensing from 1.5 days to 2.5 hours was that at the start of the pandemic, and as things were changing, we were mindful of guidance around screen time. At that time, we were taking advice from colleagues who were also beginning to deliver their own training online, and ourselves as well, giving sessions, and the amount of hours we were spending on the computer. So we drew on our own experience. Also, the size of groups we limited to 8 as well, again because of feedback from colleagues about managing group size. I think if we'd have done face-to-face, then we'd have been able to have a bigger group. But 8, we still tried to make it as interactive as possible. And as I say, it was really about building those relationships from the very beginning, where we hoped that people could learn from one another, and we did that with the kind of the carefully thought out icebreakers that we did, and the pause for reflection, and lots of opportunities to ask questions. So welcome session 1, which was all about setting the scene and the context for why we were doing this project, explaining what we wanted to test and why we thought that was important. We explained how SLAM was set up. So SLAM's a big organisation covering 4 large London boroughs. So even explaining the geography to people that may not be familiar with the trust, and helping basically the champions to understand, if they didn't already, where this project was being run. And I think then we went, after we'd kind of explained the setup within SLAM and where we'd be recruiting the beneficiaries, the service users, we then went through a process map and literally took step by step everything that in the way it would happen. I think it was about 15 steps in total. After we'd done that, we talked about the support from the project team, and we shared available resources. But we'd set up a Google space, an online space where champions could share the things that they found out about and they could add to and use. And then in terms of the resources, I think, again, if we'd have had the 1.5 days, then we would have had some training on specific physical health issues. There were talks right at the beginning of maybe asking the smoke-free team within the trust to come and deliver a session, or the dietitians or other experts that we could connect with relatively easily because of where we worked, and also because of being part of King's Health Partners. I think a couple of health champions said that would have been good. But then equally, as we kind of met people and we introduced people and learned about, people's backgrounds, we also found that some were experts in their own right. So some people were already doing things for physical health. So there were gym instructors, yoga teachers. But basically, we wanted to make it clear that we were the evaluation team, the research team, we were always available, one of us at least. And if there were any concerns or issues, etc., then we had links across the trust and across King's Health Partners if any expertise were needed. So then welcome session 2, beginning the conversation, that was delivered by Errol Green from SLAM Partners, and he's a professional coaching expert. And really this session was because, from certainly from my clinical experience, Julie's and other people who were helping us to build this project, we were aware of how long and sometimes how tricky it can be to navigate those early conversations with people, and the importance of building those relationships. So we wanted to provide an opportunity and give space to be able to talk about the early conversations that the health champions might be having, how they might start to build and establish relationships, how to contract as well, and also how to hold each other to account, especially in terms of weekly goal discussions and goal setting, which was part of the programme. Essentially, what we were doing there was looking at the very high level coaching techniques that they could use to inform their approach. It was only an hour long, so it wasn't really coaching training as such, but as I say, it provided that food for thought, and we had some really positive feedback. So much that as we were going through and we were thinking about the end of the project, we also planned to do an ending the conversation piece as well, because we understood that the relationships people were building over the 9 months, how are they navigating the end of those as well. I think because of how it was staggered and our recruitment and how people finished at different times, in the end, we didn't have that group. But by that point, Julie and I had also completed our own foundation level coaching qualifications. So we ended up having basically one-to-ones with the health champions as they were finishing. And I think that fulfilled our aims, although it wasn't in the group setting. Once people had finished both welcome sessions, they were able to be matched. And matching was basically how we introduced and facilitated the introduction of the health champion to the participant. So the matching, we'd asked people if they had any, the beneficiaries, if they had any preference in terms of who they worked with. So, was there a gender preference? Was there an age preference? Were there any other kind of concerns people might have and who they might be partnered with? Largely, there weren't any concerns. And so how we the kind of the crux of how we ended up matching was down to location. So we were mindful that if somebody was in North Southwark, that we didn't want to be pairing them with somebody in South Croydon, because travel times or distance to meet would just make it that much more difficult. So we tried to match people locally. I think, of course, there was again another challenge doing this remotely. Some people had used video calls, others were just on the phone. And if you ever try to do a three-way call with people that none of you know each other, then that can be quite tricky, and you'll appreciate that. But I think, yeah, from my experience, that it was useful. I think it later on, as we were able to do that face-to-face, that proved better. But again, I think it provided a fail-safe, if nothing else, for that initial interaction. And Ubong did the majority of those. He was the person that facilitated those, and he was available later on as well, or for follow-ups if people need a little bit more session. And then lastly, just to talk about supervision. So these sessions were run monthly, and we did 2 a month, and we made them as drop-ins. They weren't compulsory, but if we didn't hear from anybody in a month, then Ubong would usually follow up with somebody, or in his absence, Julie or myself. And again, we were mindful of the kind of the preconceptions that people might have had about supervision, so we made it clear that they were a protected and confidential space, that we want to be able to share the personal experiences of the project and working with service users. It wasn't ever about us telling people what they should and shouldn't be doing. And we basically facilitated the attendees to lead their own discussion. So every session was run more or less the same. We went around at the start of every session, and people introduced themselves, and then we asked if there's anything that they wanted to discuss. And some people brought something every time, and others kind of used it as a place to listen and reflect. But I think I don't think there's been negative feedback about the supervision, and I think people really did find it a good space. And the thing that they've got most out of it, that I've heard, is that they were able to support one another and learn from one another. I think lastly on supervision, it was really important in these sessions to have 2 of the team available. So usually it was me and Ubong. Occasionally Julie covered my role, and that was because it brought together skill mix. So in terms of the experience of providing group supervision, myself and Julie had that experience before, but also Ubong's knowledge and relationship, because he had this kind of direct contact as the volunteer coordinator, and that was important because it meant that afterwards we always had a debrief to see if there's any learning for us that helped us to tailor our approach for perhaps the next training session we delivered, or the next supervision session, or if there was anything that was kind of just we were becoming aware of that we needed to act on for safety or whatever, for confirmation for people. And I'll stop there. Thank you.
Thank you, Ray. That's perfect. So I'm just going to tell you a bit about what we found. So what I should have said at the beginning was that we recruited people through community mental health teams in SLAM. We recruited 48 participants, and 27 had a health champion and 21 had usual care. So we had a randomized control trial where we wanted to see if there was a difference for people who had a health champion compared to the people that didn't. And you can see the sort of demographics that we have of the people. So just over half were female. There was a mix of ethnic backgrounds, and we had quite a large age range, as you can see. Next slide, please, Gracie. So in terms of our findings, in terms of the sort of clinical effectiveness, or what was the difference that we made to, that it made to people's lives, we did outcome scores, as I said, and we measured things like quality of life, how in control people felt of their health, and loneliness, and we asked people to complete those before and after the intervention, so before or 9 months afterwards, and we didn't find any difference in outcome scores. So there was no difference for the people that had health champions, which I guess was disappointing for us because we thought that there would be. But what we did find was we did interviews with people who had a health champion, and we asked them firstly, you know, what did they want to get out of it, and then what had they got out of it? And you can see that there's different things that people got out of it, and you know, really significant things for people. So people talked about losing weight, no longer being pre-diabetic, making positive lifestyle changes, and then also some things that were not linked directly to people's physical health, but people talking about going out more and feeling more confident. And you can see there's some quotes there about what people said about what they got out of having a health champion. Next slide, please, Gracie. And then when we asked people about how it was implemented, so we were interested in whether it was acceptable to people, whether it was feasible, and whether it was appropriate. And most people said they had a positive experience, and when it wasn't, it was for sort of logistical reasons often, rather than anything to do with the health champion. What people talked about as the sort of facilitators very much was about their relationship with the health champion, and the things that people talked about was, you know, having that trust with someone, having regular contact. And people also talked about having someone who was independent. And I think often what people meant by that was having someone who wasn't part of their care team, but also wasn't part of friends and family. And people talked about being able to kind of, you know, share things with their health champion and discuss things with their health champion that sometimes they hadn't really ever discussed with anyone else. So that was really positive for people. The main barriers, I think COVID was a real barrier, mainly because it meant that people couldn't always see each other face to face. And so people talked about that being quite difficult, though often what happened was once people could meet face to face, because they'd already had contact and it was usually by phone, they developed enough of a relationship that once they met face to face, actually it felt like a really good relationship. And also people talked about the barriers that they had to their own goals, and people talked about, you know, the problems that I think we all have, but also that people with severe mental illness, you know, it's kind of amplify for them is around motivation was a big thing, that even though people had this support, they weren't always motivated to be able to work towards their goals. And then again, we've got some quotes on the other side of the slide about what people have said about that experience. Next slide, please, Gracie. We also asked the health champions about their experience. And I think, as Isabel said, you know, people volunteer for lots of different reasons. And it's really helpful for us to understand what they got from being a health champion. The vast majority found it a really good experience. They said that they enjoyed meeting people they wouldn't have normally met. They gained understanding of how people manage, increased their knowledge of mental illness. And I think what some of the downsides for people was about balancing being a health champion with other things in their life. And I think what happened for some people, 9 months is quite a long time, isn't it? So when people's life changed, that could potentially be difficult for people. So we had people that were students when they came in, and then when they got a job, that just, you know, was quite difficult for them to then balance being a health champion. And you can see again on the other side about what people said about their experience. So what we're going to do now is we have a video of people's experience. So we've got 2 people who had a health champion, one of our health champions, and then Ubong, our volunteer coordinator. So we're going to show you this video now.
So if you had this person that didn't have much support, you had this health champion that would take them towards their goal, as in going to the gym or going to this place, or just having someone to talk to, that is so important. And that's my point, and that's what I noticed. And that's, as I said, that's what I noticed, the importance of this. Yeah, basically, yeah. Because I want to give something back to the community. Do you know what help I've had over the last years? I've come across some absolutely fantastic people, and I wish that I had all this available to me when there was nobody. 20, 30 years ago, when none of this existed, I was just brushed aside. No one was interested. It was just get on with it. Now it's huge. It's well known. It's very documented, and it's something that's really close to heart because of, obviously, and I'll never be in the position that I am today if it wasn't for not so much the tablets and all that, it's for the people that cared. And that is the most important part, and that's the most important cog. And I want this to continue. And I just want to be that person for that young person that I needed when I was 16, 17, or, you know, I've got so much to give. I've got so much experience. And I just want to give it all, get back. I just want to pass it on. And that's it.
I found having a health champion amazing. I found it life-changing. And I found it safe. You know what it's like. You don't, personal hygiene goes out the window, housework goes out the window, etc., etc. And I just flipped that a bit. Well, quite a lot actually. And my symptoms were really, really chronic. But if I didn't, I think if I could take away one word, if you were to pinpoint me and say, just give me one word, I would say trust. Because I used to think, oh, for me, it's all down to whether I'm ready or not to accept someone like a health champion or other forms of help. But to me, I've always been ready. It's been about trust, that person coming along that you can trust. And it was Julie. And I'm not going to start gushing at Julie and my health champion, yeah.
But there's a lot of answers to this. Okay, one of my answers is because I was very inexperienced about mental health, you know, and I wanted to know more because I feel like there's a philosophy that I follow. If you don't know about something, learn about it. And that's what I went to do with being a health champion, and it worked. And it just made me realize how what the media portrays sometimes it does feel over-exaggerated from what I experienced from being a health champion. And I loved the experience. It also showed me that there's different ways to get people to open up, and I love that. And it gave me a sense of, because I'm a man who loved the sense of community, and it made me build up the sense of friendship to the individual that I was helping, and I love that. I mentioned this, I thought, I don't feel like I'm the right person. I don't feel like I'm helping this person because he's not saying nothing. It's like, am I doing something wrong? Do I need to do this? Do I need to do that? You know, but eventually over time, the person started to open up to me more because I seemed, how do I say this, human. Yeah, in a way. But yeah, that's quite a quick, brief, if I can say quick, of my experience of being a health champion. Like I said, most of the information I got for mental health was, be honest with you, media, but now I'm seeing it in a different outlook now, and that's one of the great takeaway of being a health champion. That was one of the best takeaway. And also the fact that the individual, he said this to me, and I remember this. He said to me that I was a good one. Don't put too much stress on myself. I'm doing good. Yeah, that's something that I remembered, and that's something that's not gonna leave me, because I thought I was doing bad. But the fact that the individual said to me that I'm doing good, I'm stressing too much, to me, I call that mission accomplished. And the fact that 1 week, no talking, the next week, many secrets to tell. Yeah. And so it taught me patience and just taught me that there's you can't communicate with everyone the same way. Some people you need patience. Some people you can't use this communication with them. You have to use a different method. So overall, it just taught me that it taught me really the individuality in ourselves and the sense of identity that I loved. And yeah, I can talk all day, but that's the main points I would like to bring out.
It was challenging at first, to be honest with you, because it was like kind of my first experience, my second kind of full-time kind of job. And so, I don't know, just being considerate, having that open ear, listening to people, being adaptable, versatile, and also listening. I think you just listened, and that was the main thing. And because of my own personal experience, I can kind of not necessarily say I've gone through what they've gone through, but I can kind of resonate with it. So that kind of helped me. When I found that, it helped me a lot. I thought that me doing the job that I was having to do, it helped me a lot. And because I have got experience, I can relate.
So I just want to say thank you to Charlie, Sarah, Isiaka and Ubong, who agreed to be recorded by us. And I hope that you get a sense from their experiences of what people got. And I think they're very powerful and says it much better than anything that I can say. So what have we learned and what next? So I think one of the things that we've learned is that having a health champions can make a big difference to people's lives. And you heard Sarah there talking about, getting a job. And she came from, not feeling that she would ever be able to go back to working again. And other people talking about the difference that it's made to their lives. And I think what we're thinking about now is how do we use this model more widely with people with severe mental illness? And I think what we need to think about is, and I think Isabel talked about it really well at the beginning, is I think what's really important is having the right support for the volunteers, and that needs investment and it needs to have resource. And I'd like to say thank you to Isabel, because we wouldn't have been able to do this project without her and having that support from the SLAM volunteer service. We're also interested in whether this model could be adapted for use with other groups, and we have interest from different people about thinking about different groups that this potentially could be used with. So potentially people like carers. And I think for me, I think it'd be an interesting way to go. I think we just need to think about what the focus of it would be. So this has been a really whistle-stop tour of what we've done. So now we're going to have a Q&A session, and Ray and Isabel are going to join me, and I'm going to hand over to Gracie, who's going to chair the session. Please do put any questions that you have in the chat, or if you want to put your hand up and want to come and ask that, then you're very welcome to. So I'm hoping that
Thank you very much, Julie. And I have to say, it really is just amazing being able to sit in and listen to all the work that has taken place as part of this project. And as Julie mentioned, we're now going to discuss a bit more together about kind of your ideas and reflections and questions that you may have about this piece. And whilst we're kind of doing a little bit of preamble, just to invite you really to offer any thoughts there in the chat. But I just want to kind of say one thing, which is I think it's so challenging to showcase a project of this complexity in just an hour. And I think we are so conscious and aware that there are so many parts to this that have been delivered over the last year or so in particular. And I think really as part of this Q&A, what we're keen to do is to think with you about a few key things. One, the uniqueness of this intervention is key for us. The fact that we were concentrating on physical health goals for adults with mental illnesses and the challenges that they may face, and how we can work with them discreetly to think about things they could do to improve that well-being, but also to kind of work towards goals that were important for them as part of their journey of recovery and well-being. And we're very aware that there may be other similar interventions around, but not one that concentrates on physical health as a priority. So we're definitely interested to explore your thoughts as an audience about that, and in particular, as Julie mentioned in the last slide there, about how we can go beyond these findings and apply them beyond the work we've done here. So while I just let that kind of thinking percolate, I do have a few questions, but I see already we have a hand raised by Trevor. So I would love, Trevor, to invite you to ask your question. If you are happy to come off microphone, hopefully you can do that, and please do ask away, whatever your question may be.
Yes, good afternoon. Can you hear me? Yeah.
Yeah.
I had to dip out for 5 minutes, really annoyingly, so apologies if this was actually mentioned. I'm involved in social prescribing in London, which obviously this forms a part. My two queries. You mentioned at the start that the genesis from this was from a similar Oxley's programme. So I wondered if that programme was still going and if you'd kind of cross-referenced your outcomes with theirs. And in terms of outcome measures, you were talking about, you had a lot of soft information, but not necessarily any changes to outcomes. I was intrigued to explore a little bit more what outcome measures you were using, because this is a big challenge in sort of prevention, wellbeing and social prescribing generally, as to come up with the recognised metrics that the kind of system recognises, which then obviously enables you to build scale, capacity, etc.
Yeah, thank you, Trevor. I'll hand over to Isabel just to ask about the Oxley study. Isabel, is that still going?
No, the Oxley's Befriending Community Health project finished, and they took on another project. The difference between that and the one that we have had was that the volunteers who were health champions actually did an accredited qualification whilst they were doing that. So once that was completed, the project ended, which was fair enough, because that's what they set out to do, to look at that and how qualifications could benefit volunteers. We looked at that at the very beginning, but we felt it wasn't necessary for what we were going to do, as in have volunteers gain accreditation.
Thanks, Isabel. And then to answer your second point, Trevor, and it's a really interesting question. So we really struggled at the beginning to think about what our outcome measures could be. And I think that was for various reasons. One was that because this wasn't diagnosis specific, we couldn't look at a diagnosis specific one. So for example, if it was just around diabetes, for example, we could have looked at changes for, you know, various measures around that. We looked at the research that was out there, and there wasn't very much for this kind of thing. So our main outcome measure is it's actually an economic evaluation measure. It's called the EQ5D5L, and it asks about really specific things. So it asks people about self-care, mobility. There's 3 others as well. I can't remember off the top of my head what they are. Then we also ask people around, we use the patient activation measure, which is asking people about how much in control they think of their life. We also used a mental health quality related outcome measure called REQUAL. And we used one about treatment burden, which is called a multi-morbidity treatment burden questionnaire, and a loneliness scale. And we thought that within those, we would hopefully cover what people would change for people's life. And the fact that it didn't, I think, is interesting. One of the things that I want to do is have a look and see if there were any changes for anyone, and just get a sense of it. I mean, it's a really small sample, but just were there particular groups of people for whom it made a difference and people that it didn't make a difference to. And then I think it's about thinking about how do we capture the things that did change? And it's much more difficult to do that in quantitative measures. And, you know, for some people, you know, very scientific people, they won't like that. But for other people, I think they're much more open to, well, actually, what did this mean for the person? And how do we capture that? And I don't think we have got to the bottom of that, Trevor. So any input that anyone's got, especially around sort of social prescribing, be interesting to know if there are any measures that are used in social prescribing around those things.
So most of the measures that you actually listed are kind of in circulation.
Yeah.
But there doesn't seem to be any coherent agreement on what good looks like. NHS England seem to be pushing PAM and ONS4, but so.
Yeah.
And as we're currently just in talks with Healthwatch in South East London about doing a piece of work around this to see if we can try and get underneath it. Because there's lots of conversations going on at the moment in South East London around prevention and wellbeing and equalities and deciding where they're going to put a limited pot of money. But they are making a very clear signal. They want kind of robust evaluation methodology. So it's a challenge.
Yeah, absolutely. Yeah, absolutely. And I think it's something that does need more work being done about, how do we capture those changes for people in a way that can be used by commissioners and funders to make those decisions. So I think it's going to be an ongoing issue for a while. And good luck with that project, Trevor. It sounds very needed.
Yeah, I mean, is there any way this can be taken back to King's Health Partners?
Well,
because in theory, so I know you're part of it, but in theory, this outcome discussion applies to actually a lot of work in mental health in particular.
Yeah, absolutely.
And I just wondered if one of the recommendations could be a kind of further piece of work or something.
That's a great idea, and I hadn't thought about that, but I think that is a great idea, Trevor. Yeah, so thank you for that. I think it can definitely be one of our recommendations about how do we evaluate something like this. Yeah, thank you.
Thank you.
Trevor, thank you so much. Just such a helpful question, I think, to enable us to think a little bit more critically about this work and the application beyond what we've done here, which is so useful. And we've actually had some sort of associated kind of comments in the chat. And I think Ellie and Anna asked kind of really interesting questions relating to actually how could we think about setting up similar programs, or if we were to do this, actually, what could that look like in terms of spreading and scaling? And if I could actually maybe direct these questions in point to Ray, just to think with you, Ray, really here. Firstly, kind of Anna's direct question about what would the advice be perhaps for anyone wanting to set up a similar program that maybe you would offer, and to bring in Ellie's point there, anything additional to think about in terms of if people were thinking to scale this piece of work beyond sitting within an existing trust to another.
Yeah, sure. And I saw Ellie's comments as well, and I've read Anna's. I guess there are lots of things that I could advise, but my first one would be about how you recruit or get people to volunteer in the first place. You need volunteers to be able to do this. We were really fortunate with the project that Isabel runs the volunteer service at SLAM, and there are hundreds of people that are volunteering. So we were able to kind of capitalize on that. That being said, it still was a challenge sometimes to make sure that we had enough people in each area, the geography, the location, making sure people could access and communicate with each other easily. So yeah, think about how you recruit the volunteers. And then the second thing as well for me would be how you recruit. I mean, I'm talking about recruitment because we did a research study, but how you get the word out as well, how you implement basically if you were going to do this, because there are lots of SLAM looks after about 40,000 people in its community services. Obviously we couldn't provide a health champion for everybody, but in terms of getting those referrals in, people like saying, oh yeah, there's somebody that I think you would that would benefit from this, and getting the word out, that takes a lot of effort in the first instance. And it was a shame that after the project had ended, even months afterwards, I was still getting these referrals from people that maybe hadn't spoken to us for a year, but somewhere along the line they thought about somebody else that was in their care team that they wanted to refer. So those would be my top two. But I've actually got and I'm not sure if Ellie is still on the call, but I'd actually be really interested in throwing that question back to Ellie. For everybody else on the call, Ellie was our project manager on IMPHS at the start of the project and really helped get health champions going. She was very much part of the team. So what were your kind of what would your advice be, Ellie, if you're there and able to comment? And hello, by the way.
It was really nice to hear how this went and actually hearing the feedback from all the health champs. But I also know the struggle in terms of getting the volunteers on time, in terms, because you know, when you have a study, it's a timed issue. You have a certain amount of funding over a certain amount of time, and we had to get, you know, volunteers, and had to get people in, and had to get trying to find the right people in the right boroughs, like you were saying, Ray, was really difficult. And I think that's kind of why I was saying, what would the key ingredients be for trying to move it to another trust or trying to scale up? Because I feel like there were so many things that made what you had here a success, even if it wasn't quite to the scale that everyone was hoping for. Because actually the amount of work that went into what was recruited and how many patients you actually got in was quite a lot. So you obviously had all the experience from Isabel, you had experience from Ubong as well. You had both Ubong and Ray and Julie as well on those calls, being able to do the sessions. There was a lot of drive from some of the community teams to help recruit, and even then it was still difficult to get the right people at the right time in the right places. So I think it's tricky trying to think about how you would scale that up, but it's also thinking about the things that will like facilitate us to success, I suppose. And I don't know, because Julie, I'm not sure what plans you had for your publications, and whether you were going to try and I don't know, wrangle the whole implementation thing and see whether there was things that could be learnt from this. But it seems like there was a lot of facilitators and barriers. And it's a really difficult mix of stuff. That's why I think I asked the question, because I'm curious. I don't actually know how you would lift and like, if I say, I don't know, Nelft wanted to do it or something, they've got probably an equally challenging geography. They're probably as motivated, and I think they do have sort of a bit of a legacy with volunteering, but I think they have a different mix when it comes to research and staff and everything else. But then if you had to try and do this, you would also have to make sure you had a similar sort of pipeline of volunteers, a similar sort of access to, I don't know how you would do the geography and everything else, and make sure that you had someone coordinating it and all that kind of stuff. So
yeah, I mean, I think that coordination is really, really key, because I think it's about supporting the volunteers properly so that they feel kind of safe and supported. And it's also that kind of logistics, as you said, of kind of, you know, having big geographical areas and how you kind of do that. And also I think, as Ray said, you know, how do we encourage more people to volunteer, especially, you know, there's a lot of evidence of, you know, that people that volunteer tend to be older, more female, more white. How do we kind of, you know, how do we encourage that? And I think there's a lot of work going on at the moment. So the King's Fund have just put out a couple of really interesting reports about volunteering in health services, where they kind of talk about that. How do we change who volunteers, and how do we change that kind of image of volunteering, I think. Which is why it was really nice to have Isiaka talking as the health champion, because he's a young black guy, and you know, he talked about the challenges that he had, because he was, you know, not very confident. He was much less confident than some of our other people, but actually I think with support he was able to do it, and you heard that what he said and how much he got out of it as well. And I think you know, in terms of implementation, I think there were actually more facilitators than barriers, actually, in lots of ways. And if you're not doing it as a research project, you don't have that time element necessarily. So I think that probably would make things easier. But the key things I say is, how do you support the volunteers, and how do you get it known that you have this kind of, you know, service available to people, and help people to understand what it means. I think one of the things that we should have been better at was doing more work with our service user participants to explain to them exactly what this would involve, because I think there were a few times when people didn't really understand what it was that they were getting themselves into, and so it didn't work as well as it could have done. So I think, they would be the key things, but hopefully we can put all of that together in our toolkit. We're also going to have a couple of academic publications, one which will be the main results, and then one which is much more qualitative, looking at the implementation. And also we're going to have an infographic and a lay summary, so that we can get this out to kind of as many people as possible and make the information as accessible as possible.
That's really cool.
I think we've probably run out of time now.
We have. I'm sad to say. Ellie, thank you so much just for your contributions there. I think Ray was absolutely right to bring you in and hear directly from you. And I appreciate there have been other kind of comments in the chat there, particularly from Faith and Rachel. Just thank you so much for those. And I've just even had a final hand being raised just to kind of check in, just to say I think we may have come to time on our Q&A, but if you did want to ask your question, I really encourage you to add that to the chat, or of course you can email our team at imphs@slam.nhs.uk, and we're really keen to keep talking on this as a project and all the work that we're doing in the entire programme. So we really are kind of encouraging everybody to keep in touch with us, and what we'll do after today is be in touch with some of the details that Julie mentioned as well on the toolkit and the papers, and when you can hear a bit more about when they'll be coming through. Thanks so much, Julie, for adding that email back in the chat there. So Julie, I think I'm handing over to you, and I thought the kind of final thank you. Before I do that, just a huge thank you to Isabel, Ray, and all those that contributed in the Q&A. I'll hand back over to you now, Julie, for the final part.
Thank you. Very, very briefly. Biggest thing from me is just to thank everyone who took part and who helped us with the project. So all of our service user participants, all of our health champions, all of the staff in SLAM who supported us, the IMPHS team, this amazing team that I've been so lucky to work with, and also our funders, the Maudsley charity, who have been amazing, and Isabel, who also we couldn't have done this without her. We've got the IMPHS email address there. If you want to contact me directly, this is just my personal email and Twitter. And then just if the next slide, Gracie, this is just a couple of references around physical health, around volunteering, and then also the link with our protocol paper. And we hope that the results paper, which is being written at the moment, will be published not too long. But also the toolkit will come out in early new year. And if anyone is interested, please let us know. So that's all from me. Thank you very much to everyone. I'm going to hand back to Gracie.
Thank you so much, Julie. As we've kind of reached the very end of this webinar, again, it has absolutely flown by. I think on behalf of the entire team, I just want to kind of convey my personal thanks. This really is one of a real kind of flagship parts of our overall project within IMPHS, and I think we're immensely proud of it. And I think we really recognise that there's opportunity beyond what we've delivered here. So just for everyone who's offered comments and reflections, please do keep talking to us, because we're really keen and we are thinking actively about what we can do next with this work. And if you're interested in talking with us, we're really keen to hear from you. But it is important for me to say that we are doing an entire series of webinars, which are here on the screen. They will showcase in turn each of the individual projects that we've been delivering over the last 3 years. We delivered our first webinar last week, and you can watch that back. The link here we've included for you, and we will share these slides. And we, of course, really encourage you to join us for future sessions. I'll add the link in the chat in just a moment. And before we come to an end, I will launch a poll. With all of these webinars, this is the first time we've done anything like this, and we're really keen to understand if these are of interest and of use. So I'm going to just launch a poll, and I would really just ask on, from our perspective, if you could just take a moment to answer the three quick questions. I'd be very grateful, just so that we can make sure that this is kind of reaching all of your needs and interests. And if there's other things you think we could be doing for the future, we're keen to think about that, to bring as much information and share as much as we can with you in the months ahead. All that's very left for me to say, I suppose, is thank you. And again, our details are here on the screen, just for the final moments there, if there's anything else you'd like to capture. I think we are now at time for the end of today's webinar, so I'm going to stop sharing my screen and just say an enormous thank you to all of our speakers and guests. And I wish you all a very lovely rest of your Wednesday afternoon. Thanks so much for joining us, and we hope to see you again very, very soon.
Thanks, everyone.
Thank you.